Bismillah ar-Rahman ar-Rahim. It's my pleasure to be with you on the 9th Libyan Congress of Cardiology. We wish to be here, but for some reasons with the issuing the visa, we could not be with you. We promise in a very short time we'll be doing workshop here in Libya. I'm Dr. Mervat Aboulmaaty, a professor of cardiology. I'm going to present to you a basic electrophysiological study. I am the current president of the African Heart Rhythm Association. I would like to thank my fellow Ahmed Rastasi for helping me to present this lecture. I don't have any disclosures. In order to understand electrophysiology, we'll go back to our basic anatomy and electrophysiology. The sinus node is the node which is located in the high right atrium at the junction of the superior vena cava and the right atrium. The AV node is located also in the right atrium before the tricuspid annulus, near the septal leaflet of the tricuspid annulus. The His bundle is the bundle which penetrates the interventricular septum and divides into right bundle branch and left bundle branch, and these branches, this left and right, will give the Purkinje fibers. This is the anatomy we studied in medical school. The objective of the basic electrophysiological study is to assess the integrity and the function of the conductive system, the SI nodal function, the AV nodal function, to induce tachycardia and study the mechanism of the tachycardia, and then finally to perform a radiofrequency ablation, which is a curative treatment. Starting the EP procedure, we have to explain to the patient all the steps. It is done under conscious sedation, or sometimes without sedation. We use local anesthesia. We get our vascular access, venous mainly. Sometimes we go arterial if we want to go to the left side of the heart, to the aorta, to the aortic cusps, or we do transeptal puncture to go to the left atrium. We have to study the shape and the numbers and the types of the catheters. We have mapping catheters, and these catheters are connected to pacing system, external pacing. I will show you everything. We place the catheter under fluoroscopic guidance, and then we connect it to multi-electrode recording system and a programmable stimulator, which is like a pacemaker, external pacemaker, but has the facility of delivering extra stimuli, and this extra stimuli depending on the site where it is delivered. Then we have the 3D electroanatomical mapping, which is now incorporated in many cath labs as essential part of electrophysiological procedure. This is the shape of a quadrupolar catheter. We have to understand the connecting port of each catheter in order to get the proper cable. The manufacturer should provide you with all the cables, and some catheters are connected even from the same manufacturer with different cables. The spacing between the electrodes is as shown here, maybe 2 millimeter, maybe 5 millimeter. There are some deflectable catheters. We have decapolar catheters, as we can see here. These decapolar catheters, 2, 5, 2, 5, and so forth. And some of them are fixed and some of them are deflectable, as you can see here. This is the ablation catheter, which has a 4 millimeter tip in order to perform ablation using it. Here is the cartoon of where we place the catheter. Here we go from the inferior vena cava and we place one catheter in the right atrium, one catheter in the right ventricle, and a third catheter at the AV ring, at the tricuspid annulus between the atrium and the ventricle, and this is the His catheter. Each catheter getting its name from the position where we place it. Here we can see that we can place the decapolar catheter, which is 10 pulse catheter in the CS, the ostium of the CS in the posterior right atrium. We negotiate here and we introduce this catheter, and this is a very good catheter to get recording of the left atrium and the left ventricle. On fluoroscopy, we use two views. We use the LAO view and use the RO view. And we can look here, we can see that this is a decapolar catheter from the left subclavian. This is the His catheter, this is the RV catheter, and this is the right atrial catheter. This is a video we can, after giving local anesthesia, we go get the 3 venous punctures on the same side. Sometimes we use 2 sides if we are using more than 3 catheters. We make sure on fluoroscopy that the guide wires are on the right side of the heart, as you can see in this video. We have to make sure that we are not in the left side if we don't need to be in the left side. Here is the placement of the decapolar catheter, as you can see in the LEO view. We negotiate the CS ostium, and then we push the catheter gently to be introduced into the conosinus. Here is decapolar catheter in his region. Here is the patient in the cath lab. This is the fluoroscopy machine. This is the AP system, and this is the connecting interface which the catheter is connected to and is connected to this EP machine with its all channels. This is a real picture of one of these machines. We have a desk where everything is settled. This is the GE machine. This is the stimulator I told you about. It looks like it can deliver a pacing extra stimulation to any chamber or any port we are connected to it. This is the radio frequency ablator, and this is the infusion pump. This is the C-arm. This is the biplane, which is sometimes available in many labs, in some labs. And this is the integrated screen where you can see the fluoro, the EP, and the stimulation. Here is we can see the intracardiac and the fluoroscopy at the same time. The patient should be connected to the ablator by a pad on the back of the patient, on the back of his chest. And because we are doing unipolar ablation, and we have to monitor for the temperature, the impedance, the time, and so forth. Here again, the catheters, the catheter placement, the decapolar catheter in the CS, the His catheter, and the RV catheter. There are different types of catheter. We have, as I showed you, this is a 4 millimeter ablation catheter. This is an 8 millimeter ablation catheter. This is an irrigated tube catheter. And this is the handle where we can move the catheter between 180 degrees or 360 degrees. In electrophysiology, we have to measure, and we measure by millisecond. And millisecond, of course, is 1/1000 of a second. The cycle length. We talk about cycle length, which is a single point from one cycle to another cycle, the same point. And this cycle length, if you want to understand, it is the 60,000 divided by the heart rate. If we have heart rate and want to convert to cycle length, we divide also 60,000 by the cycle length in order to get the heart rate. In short, if we have a heart rate of 60, then the cycle length is 1,000. If you have a heart rate of a cycle length of 1,000, so the heart rate is 60. We have definitions and nomenclature which we should understand and explain to our fellows before we start. S means sinus, A means atrial activation, H means His bundle activation, V ventricular. S1 is the train of pacing in whatever chamber. A1 is the atrial activation resulting from S1. H1 is the His bundle activation resulting from S1. V1 is the ventricular activation resulted from S1. So S1 is the paced train. S2 is the first premature exostimulus. S3 is the second. A2 is the atrial activation resulting from it, and H3 is the H resulting from the activation of A2, A3. Refractory period, as you know, is the effect. We have two types. Effective refractory period is the one we measure always. Is this longest S1, S2 that fails to depolarize the chamber being paced over the AV node. Functional refractory period is the shortest S1, S2 that depolarize the chamber being paced over the AV node. Okay, to simplify our understanding of the intracardiac reporting, if we have a catheter placed into the right atrium, the surface ECG is is mandatory in all tracings. Remember, P, Q, R, S, T. So any signal which coincides with the P wave in sinus rhythm is the atrial activation. Okay, easy. If we place a catheter in the ventricle and we have normal sinus rhythm, so we have PQRS, PQRS. So the ventricular activation or the activation recorded by the catheter, which is placed into the right ventricle, is the ventricular activity. If we place a catheter at the tricuspid annulus near the septal leaflet or near the septum, and this catheter is looking at the atrium, looking at the ventricle, and is getting a sharp deflection, which is called His deflection. So we have the His catheter is recording A, H, and V. If we place a catheter in the coronary sinus, then we can see that it looks at the left atrium and the left ventricle, and we have A and V, A and V in the CS. We know the numbers of poles. It starts by distal to proximal. So this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good. The sinus cycle length is the interval between two successive A waves. After we place the catheter, we have to measure our basic intervals. So we start with the sinus cycle length, AH from A to H, HV from H to V, and sometimes we can measure the duration of His deflection itself. Here is an example from real EP lab. First, we have to have surface ECG. We choose the limb leads and we choose one or two of the chest leads. The limb lead 1 and 2, the chest leads V1 and V6. In case we get any right bundle, left bundle, then we can make proper diagnosis. We make the speed faster. We make the paper speed 100 or 200 milliseconds in order to look at these signals clearly. This is normal sinus beat. This is normal sinus beat. We have the atrial catheter placed in the right atrium. It's getting our first deflection. Then the His catheter, A, H, V. Then we have the CS catheter, A and V, A and V. And then we have the ventricular RV catheter in the right ventricle. We make colors for each chamber so that your eye will get used to it. So in this case, His catheter, the distal and proximal, distal means 1 and 2, proximal means 3 and 4 poles. This is quadripolar catheter. The decapolar catheter is the one in the CS, and we start by 1, 2, 3, 4, 5, 6, up to 9, 10. The RV catheter, we used only one pole in order to use it for pacing and recording. So each channel representing one catheter is one color, and you have to fix this color in your lab. If you go to the printout in order to make measurements and to explain this in black and white, here is the cycle length from atrial activity to a next atrial activity, similar one, and this is the cycle length. We have the AH and we have the HV from the low septal right atrium, which is the His catheter, to the His deflection. We have the His duration. This is the His bundle duration at bigger speeds. And then we have the HV interval from the His to the earliest or the first ventricular electrogram. This is the CS catheter showing that from proximal to distal, because it is the CS ostium is the CS catheter is located 9, 10 is near the ostium, and 1 and 2 in the left atrium. Starting with the sinus node function, this back to bench to test if the sinus node is well functioning. We have two measurements. We have sinus node recovery time and we have sinoatrial conduction time. In the sinus node, each one has its own numbers. After that, we do atrial extra stimulation. We deliver, this is the right atrial catheter, and we deliver a train of 6 or 8 beats and one extra beat, and look at the response of this beat. Let's see. Here, atrial pacing S1 As we said, S1 means paced. AHV, AHV, and this extra stimulus is closer to this train because the coupling interval, which we call it S1, S2 is 400. So the train is 500 millisecond, S1, S2 is 400 millisecond, and we look at the response A2 to S2, H2, and V2. So this is conduct. This is a sinus beat, AHV. You look at the AH here is longer than this because we are encroaching on the effective effect period of the AV node. As you can see here, we are getting closer to the S1, the base train, with the extra stimulus, and the response is getting delayed because the AV node has this function. As you can see here, atrial extra stimulus, AHV, and still conducted. Then we will not go to the jump and the echo, but let's look here. We have the train, AHV, 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 and we stopped here. Okay. Then we get closer to S1 by shortening this coupling interval until we don't conduct because we want to measure the AV node effective refractive period. So here, base train, AHV, 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 and the extra stimulus is early. There is an atrium and no H, no V, so this is effective refractory period of the AV node. Sometimes you get you deliver very short, early, and you don't get an atrial activation, and this is called the effective effect period of the atrium. Okay, we have here a second step in our basic electrophysiological study is ventricular pacing. As you can see here, this is normal sinus rhythm, AV, AV. Then we started pacing. When you start pacing in the ventricle, you have to be faster than the cycle length. And then after you start, you have to look how is the retrograde conduction, yes or no? And if you have retrograde conduction, what is the activation of this retrograde conduction? Let's see here. This is 12. This is ECG 1, 2, V1, V6, and we are delivering pacing from the right ventricular catheter. As you can see here, paced pipe followed by QRS complex. So this is effective. This is pacing. So we are pacing the ventricle. We are capturing the ventricle, and we are pacing from the apex because -2 and QRS V1 is QS pattern. So we are pacing the ventricle. We are capturing the ventricles, all beats, yes, 1, 2, 3, 4, 5, yes, all beats are capturing. And then we look at the retrograde A. Clear signal of pure retrograde is the right atrium. So is every spike followed by A? Yes, yes, yes. So there is retrograde conduction. Then the third question. What is the activation pattern? Where is the earliest retrograde activation? This is the His, yes. The yellow is the His. So the earliest retrograde, if we make a line here, is the His catheter, followed by the CS base at the CS ostium, and then finally at the lateral mitral annulus, which is CS1 and 2. Here we can see that VA, but the earliest retrograde is not the His. The earliest retrograde is in the CS because there is an accessory pathway located near the CS in the left side, near the CS1 and 2, and this is why we can see this activation pattern, okay? So we have here capturing the ventricle. There is 1 retrograde, and the earliest activation is not the His, it is on the CS. So this is the second point to discuss, to study. Here I'm going to show you this case, V pacing, 1 to 1, 1 to 1, 1 to 1. And the retrograde here, because we are timing everything, is concentric. So this is the meaning of concentric activation. Pacing the right ventricle, and retrogradely conducting through the AV node. The His bundle is the earliest A, followed by CS proximal at the 9, 10, 7, 8, 5, 6, up to 1, 2. So this is a concentric retrograde activation of the ventricle. If we go faster pacing, we get the retrograde Wenckebach phenomena of the AV node. So it will block here. We can see. Here, we can see that there is pacing ventricle. Yes, we are capturing all. We are pacing from the right ventricle. V, A, V, A, V, A, V blocked, or maybe V, A, and this one V blocked. So we can see here that there is retrograde Wenckebach, and this is the retrograde Wenckebach cycle length of the AV node. In this example on paper speed, this is ventricular pacing, yes, RV pacing, yes, and there is no relationship between the atrial electrogram and the ventricular electrogram, which are pacing, and this is called VA dissociation. And we like, some people don't have retrograde conduction, some people have it, and this is seen in VA after ablation of an accessory pathway. Ventricular excess stimulation is used also to disclose accessory pathways and also to induce ventricular tachycardia. We can use single, double, and triple excess stimulation during ventricular tachycardia induction. And let's see, look here, how does it look like? So this is ventricular pacing, the last paced beat in the train, and this is a ventricular excess stimulus, and we study the response to this ventricular excess stimulus. So we look at the train first, we look at the activation pattern of the coronary sinus, and we can see this is concentric, and this excess stimulus is also showing concentric activation. So this is retrograde conduction to the AV node. And when we get closer or shorter with S2, S1, S2, then we get decremental conduction also through the AV node, and with keeping the same concentric retrograde activation pattern. Then we deliver the excess stimulus, no V, so this is the effective refractive period of the retrograde limb of the AV node and of the ventricle at the same time. This is here on paper. We can see that here, this is the second, the S2, which is the first excess stimulus. The train is going down to the AV node, to the atrium, but the excess stimulus is blocked, as you can see here. So this is the ventricular retrograde activation pattern, and this is V, no A. So this is the effective refractory period. We can see it here. As you can see, this is a train of ventricular pacing, and this is the excess stimulus, and still we have the VA time and his retrograde. This is the retrograde concentric activation, and we were lucky to see a retrograde his on this channel. Then we paste, we get the ventricular activation here from the surface ECG and from the ventricular signal on the other channels, and then V, no A, so this is the effective refractory period of the retrograde limb of the AV node. And finally, we got the spike, no V, so this is the effective refractory period of the ventricle itself. This is an example of concentric activation of retrograde conduction, and we saw this. At the end, I would like to thank you for organizing this wonderful meeting, and next time we'll have good workshop with you, and thank you very much. Dr. Mervat, Aboulmaaty.